Good morning. For those who I haven't met before, my name is Tracy Hart, and I'm the director of the OI Foundation, and I wanted to add my welcome to all of you for being here. I hope you had a great night last night. I hope you walked and wheeled with us through the hotel, and you met some new friends, and you connected with old friends. Just so happy to see everyone here together. This is what we call our research update. We're going to hear about some programs of the OIF. We're going to hear about the science, and we're going to do some other kind of fun things here in just a minute. But first of all, my colleague, Erica Carter, wherever she is back here, she's our Chief Program Officer. We wanted to give you a little bit of an update on some of the OIF resources, just to make sure that you know what's available to you and to your families. First, though, I wanted to see if there was anyone in the audience from Canada. Are there any Canadians here this morning? Where's it? Oh, okay, great. Yay! So I'm pointing you out because we have a wonderful relationship with the Canadian OI Society. And I serve on their board of directors, and we do a lot of partnership activities together. Some of the materials that you see that we have out there are translated into French, and that's all because of our friends at the COIS. So I want to make sure that the folks from Canada connect with each other as well, and I know Erica's going to talk about that in a minute. I'd also like to quickly thank our sponsors again for supporting us. We're just so appreciative of their support. And this session today is sponsored by our friends at Ultragenics, and they have a table out here in the hallway, so go connect with them if you haven't been to their table yet. So before we start with the actual presentations of the science and programs and whatnot, at the OIF, we don't give out a lot of awards, but we do have a couple that we try to give out to special people. And one of those awards is called the Thelma Clack Award. That's our Lifetime Achievement Award, our service award for a volunteer who has been involved with us for 10 or more years and is a true volunteer in all senses of the word. So the recipient of the Thelma Clack Lifetime Volunteer Award will be someone who has served the OI community for 10 or more years in the areas of awareness, fundraising, volunteerism, service, advocacy, and/or involvement with the OI community. They also give without thought of reward or recognition, demonstrating a spirit of willingness to put others before self, as demonstrated by Thelma Clack. We're going to do that in a minute because I just messed up and realized I didn't give Erica a chance to speak about the resources. So back it up. Erica, it's all you.
I won't take too much time. Erica, my name is Erica Carter. I'm the Chief Program Officer here at the OI Foundation. I've been here for 18 years, and conference is easily my favorite part of what we do. As Tracy mentioned, we have a lot of really useful resources that we have here at the conference at our OIF resource table, which is right next to registration, right down the hall here. So please find a moment to come find me or our health educator, Kenna Coleman, so we can walk you through them. Just want to point out two of our latest resources that are super useful for both you and your providers. We have our Adult Health Toolkit and the New Diagnosis Toolkit. These are available in English, French, and Spanish. They're available in print, and you can also download them. They have some really great interactive sections, one-pagers. Doctors love one-pagers, surgery tracker, medication tracker. So please take a moment to check those out and find some time to connect with us. I want to point out 3 lunchtime programs we have today. As Tracy mentioned, our Canadian OI Society is here. They're hosting a table at lunch in the Blackstone Ballroom where breakfast was. So please take a moment to stop by and see them. We also have Children's Nebraska, who's going to be hosting a splinting demonstration, and they have splint kits that they're handing out. And then finally, you've been hearing about our support group that we've revamped. So we have 5 regional support groups, and the support group leaders will be there at lunch at a table, ready to meet and greet and talk to you about the program and get you signed up. And if you're not signed up for the OIF newsletter, the e-news, the monthly e-news, please do that. And then our quarterly breakthrough newsletter, you can do that at the registration table or on our website. So with that, I'm going to turn it back to Tracy and Christine for this very important award.
Thank you, Erica. Sorry about that, guys. So we'll get back to the award presentation. I'm going to turn things over to Christine Rossi, who you heard from yesterday, who just did an amazing job kicking us all off. She is the newly elected president of the board of directors. And so Christine, I will hand it to you.
Thank you. Thank you, Tracy. Thank you, Erica. Great to be back, everybody. Have you had enough of me yet? I said it. Tracy said, I think you should kick off again. I'm like, I don't know. Maybe they had enough of me after yesterday. I'm so excited to be back. I know everybody who was here yesterday probably had a very late night last night, so we'll get things going this morning. But before we get back to the matter at hand, I do want to take a moment to recognize the OI Foundation staff. So if I could get Tracy and the team to stand up and even come to the front. Anyone who's in the room who's the OIF staff, can you please come to the front? Can you please come on up? Irene, Janine, Desiree. Can I get you all to come to the front of the room, please? Come on up. Come on down, OI Foundation staff. I want to get you front and center. All right, keep them coming, keep them coming. There we go, there we go. We got a small but mighty dream team here, I'll tell you that much. All right, so I really want to take a moment, and I love that you're all on your feet. I said yesterday the conference is like their Olympics. These are your unsung heroes. These are the people behind the scenes that keep the train moving, and despite every obstacle, we couldn't do it without them. They are fantastic, amazing, and somehow just saying the little blue ribbon that says staff didn't suffice, so I wanted to call them up and say, thank you, thank you, thank you, thank you. And as you could see by the standing ovation, the community thanks you too. So just wanted to kick us off with that. So when you see them, you walking around and you're asking them a million questions, and if everything isn't perfect and you need it, looking for something and they're solving your problem, just give them an extra thank you. So thank you again. Okay, with that, back to the matter at hand. I am so excited to have the privilege and honor to give out this award. As Tracy talked about what the Thelma Clack Lifetime Volunteer Achievement Award is about. Dr. Laura Tosi has been a member of the OI Foundation Medical Advisory Council since 2007. She served on the OIF Board of Directors for 8 years. In 2010, Dr. Tosi led the charge on the importance of the patient voice as the principal investigator of the OI Adult National History Initiative Survey. Results from the OI-ANHI survey were used to improve the information available to healthcare providers and adults who have OI and to encourage new research. Since 2019, Dr. Tosi has been the principal investigator on 4 engagement awards from the Patient-Centered Outcomes Research Institute, one of which enabled the development of the new OI Adult Health Toolkit. Her dedication to continued education about OI and rare bone diseases within the medical community has led to Dr. Tosi chairing 8 OI Town Clinic halls and serving as the faculty chair for the Rare Bone Disease Alliance's Tele-Echo Clinic series for the past 5 years. In recent years, Dr. Tosi has been leading the way on transition and gaps in adult care by chairing the Somewhere to Go Adult Health Initiative. This program endeavors to prepare the rare disease community to advocate to make impactful change around the issue of improving care and access to care for adults with rare disease. On a personal note, you heard me talk yesterday about the OI Foundation and the medical community finding gaps, us as the patients finding gaps because we fall into the potholes, whatever they are. And Dr. Tosi, every conference I've been to, every learning, Every conversation we've had where Dr. Tosi has said, tell me more, has been one of those gaps, whether it's digestive issues, whether it's pregnancy issues, whether it's cardiac issues, whether it's tissue fragility, whatever it is, Dr. Tosi comes with an open heart and wanting to hear and listen and understand. And that call to action, when I talked about that yesterday, Dr. Tosi is exactly what I was talking about. And I know as an adult with OI, it gives me personal comfort knowing that she's leading this charge. I know there will be answers because I know Dr. Tosi is so invested and so involved. I heard a lot from the OI community, even recently and especially last night, about the gaps in adult care. And, you know, for the first time in a long time, I can say we're on it. The foundation is on it because of physicians like and researchers like Dr. Tosi. So I want to thank Dr. Tosi on a personal note. Her compassion and passion for helping people living with OI, partnered with her unwavering energy, continue to make her an absolutely phenomenal advocate for the OI community. The OI Foundation is so incredibly fortunate to have Dr. Tosi as a partner, and we are honored to present her with the Thelma Clack Lifetime Volunteer Achievement Award. Dr. Tosi.
Thanks so much. Thank you tremendously. Great honor to get this reward. But you know, you can't get it unless you work with wonderful people. And really, this is a group award. This is an award to me, plus the OI Foundation, volunteers and staff, because we've all done it together. And I hope you all understand what an incredible foundation that you have, that there is such a team that is open to new ideas, wanting to make things happen, and having the wherewithal to make it happen. It's just been one of the great joys of my life. I thank you for this award, but I couldn't have done it without you. So thank you to everyone here. My talk, in fact, and I would have my slides now, so I use this and I get to my slides. Okay. Asking me to do technology is always a challenge. I don't think you understand. Okay. So I have a little bit of a personal challenge here because I need to see my slides. So we don't have, can I just hold this? Oh, goody. Oh, thank you. Whoops. I'll try not to clobber your ears. But my talk is really about this award because it's a little bit about how we get there. And I know many of the folks in the audience, but a couple of points about me you might not know. I am coming up on, I hate to admit this, 40 years at my hospital. Now, when I first arrived, my chairman said, well, you know, if you're going to get academic promotions, you've always got to have your suitcase packed and be ready to move on to the next institution. I said, that's not an option. My husband and I have lived in separate cities for 9 years. I'm pregnant, I want to start a family, and the deal is we're going to stay in one place. He sort of, you know, shook his head and said, oh, well, there's no hope for you. And off we went. But ironically, my inability to move turned out to be my greatest advantage because I've lived and watched populations grow. I'm a grandmother a gazillion times over now with all my patients. I have 2 of my own, so that's good. Love grandchildren. But I've gotten to see the evolutions in so many different disorders. And I would argue strongly that OI has been the most exciting of all the disorders I've gotten to treat. And that's pretty cool. Whoops, slipped aside. So we are involved in an extraordinarily rapidly changing disorder. Bisphosphonates have changed the world, rotting and then improved rotting. We've recognized pulmonary concerns. We're working on medications. And so this particular magazine cover is one of my favorites. There's absolutely no chance that I am going to grow up to look like Sophia Loren. It would be nice, not an option. But the live to 100, I think that is a really interesting issue for all of us. I'm at high risk. My family's lived to their late 80s, early 90s since before the American Revolution. And all of our patients are living to be older. And what is that quality of life going to be? And so what got me started was being in the same place, learning that I had real problems because there was nothing in the textbooks to tell people, this is what you got to do to stay safe. This is what you've got to be prepared for. There was nothing out there. And that was a little bit problematic. So early in Tracy's career, 2010, she allows me to run what's the annual, or I think it was annual then, to scientific meeting. And it was improving musculoskeletal outcomes for individuals with OI. And we looked very carefully at what we knew about adults. If you notice, our very first speaker, moderator, was Dr. Gloria, aging with OI. What do we know? What do we need to know? And we came to a very definite conclusion. We didn't know a bloody thing. This was not a good outcome. So the question was, how do we develop a strategy that will capture this rapidly changing story, not just for today, but for the long term? And we talked to tons of people. We went around, we had focus groups. One thing was absolutely clear. No one was going to do it for us. We were either going to do it ourselves or forget it. So I hope you love children's books. I do, but if you remember the story of the little red hen, it's clear we had to do it ourselves. Now, techno disaster that I am, how are we going to do this? How are we going to describe it? Blind men around an elephant, depending on where you stand, the front or the back, you're going to describe that elephant very differently. How were we going to describe OI? How were we going to do the data? So I was a techno disaster, but the NIH had this new question set, PROMISE, patient-reported outcome measures. And they had a URL you could use for free. So I found wonderful people who were much smarter than me to put my questions up on this. Now, I did it all wrong. And to those of you who are in the audience who answered my questionnaire, I apologized. It took over an hour to do it. You're supposed to have like 4 or 5 questions. I had hundreds of questions. I went over every body system. I asked you about everything. And we only put it up for 3 months. I had a grand total of $14,000 that I managed to raise, and that allowed Tracy to send out a letter twice saying, please help. But in fact, 959 people filled that bloody thing out from the beginning to the end. Unbelievable response. And it gave us our first sense of, so what are the issues? And I'm the first to admit we missed some of the issues. And we didn't even ask all the right questions. But we got started. We knew that musculoskeletal was your biggest concern. Hearing, pulmonary, we weren't really all that focused on. We didn't get it that the community was that concerned right off the bat. Sometimes you have to hit us over the head a little bit, but we started to see what the community was concerned about. And again, there wasn't a whole lot of data, but we were able to compare what the community was saying versus what the rest of the American population was saying. And here we did see, gee whiz, they aren't common, but heart attacks appear to be more common. High blood pressure is more common. Strokes are more common. Shortness of breath, a biggie. Sleep apnea, wheezing. We weren't totally focused on this quite yet, but you were telling us. One of the interesting things we also found is we didn't always know how to speak and to interpret. So as a clinician, I think, okay, I think mechanically, I'm a bone cruncher. We have mild, moderate, or severe OI. But we had a couple of individuals who said they had type 1 OI, but they had severe disease. Well, how could this be? Led us again to new understanding, because luckily, through no good planning, I found one of those individuals. How could it be? The individual had had full employment, walked, talked, did everything, family. The individual went deaf, stone deaf, lost their friends, lost their ability to feel engaged. Another point we were missing. We needed to pay much more attention to the issue of hearing loss. We looked at quality measures, quality of life measures. Again, with our first go round, we weren't all that smart. Thank goodness you kept talking to us. So this, I apologize that this is so hard to see, but one of the issues, if you look at sort of the 3 lines with each issue, we have pain intensity that didn't look all that bad. But then what we didn't really see the first time through was pain interference. And the dots here are mild, moderate, severe, and that pain was absolutely interfering with people's lives in a very severe way. They were outside the range of normal or the general population, and that this was going to be important to us over time. So we came back, and blessed Tracy, she let me run the 12th scientific meeting. We reported what we had done, what we had found, but we also were still a little unclear on where to go next. But one thing was absolutely clear, which was that we needed more input from the patient's voice, that you can't just let the pointy-headed folks in the academic institutions make all the difference. So you guys may not have heard of it, but there's something called the Patient-Centered Outcomes Research Institute. This was first funded at the beginning of the Obama administration. And they got $1 billion to find out what patients really thought. Interestingly enough, it's because they felt that lots of scientific data comes out explaining what people should do, but patients frequently don't do it. So what good is the research if you're coming up with all this stuff that nobody does? And so we started applying for their awards, and happily we started winning them, which was really great. And what's different about PCOR is that instead of the old thing where the doctors say this is what we're going to study, it's a two-way street. And you start right at the beginning saying, what are the important questions that we're going to look at? The patients have to buy into how we're going to conduct the study, how we're going to interpret the results, and even how we're going to share the findings. And I'm thrilled to tell you, we're now 4 awards into that. And I'll tell you a little bit more about some of the things that we've done. At the same time, thanks to Tracy's immense wonderfulness, other data that you all had helped accumulate helped the OI Foundation be part of the NIH Brittle Bones Disorders Consortium, which is the natural history study that I think a number of folks here are part of. And we're now 10 years into that, and the good Reed's going to talk to you more about the wonderfulness of that. But once again, I got to lead yet another little study looking at patient-reported outcomes there as well. And once again, the quality of life measures said pain. Come back to that in a minute. One of the outcomes of all of this, too, was that the OI Foundation developed its own registry. And I would argue, most important piece of paper out there on Erica's resource table is the resources for patients. And if you go to the back, the QR code for the registry is there. Please sign up for it. Because this is our way of getting your insights on important questions quickly. No, it's not a longitudinal study. No, it's not a medical study. But sometimes there are really important questions. And so during the COVID epidemic, what did that allow us to do? It allowed us to track who's getting COVID. It allowed us to track what were important issues. It allowed Tracy to hold those wonderful conferences to support the communities. And we found a really important piece that we were able to put into Breakthrough, that virtually no one who got vaccinated ended up in the ICU. If you look at those, me trying to be mathematical, in the middle, those green circles. So the circle on your left, we only had one vaccinated person who ended up in the ICU. But as you can see, we had a lot more in the unvaccinated. So a way to push. We also discovered that people weren't exercising, and man, oh man, did the foundation start pushing people, recognizing how important exercise is to health. But with the registry, we were able to do these quick and dirty turnarounds to know what's going on. Really appreciate it. Some of that early work then led to the impact study, which is actually an international study about what is so very important. And many people, again, from the United States, participated in that. I apologize, it's so small, but the arm going out the furthest, pain. And so it's allowed us to know we have to focus on pain in a much greater way. Now, our most recent PCORI award was called Preparing Adults with OI to Engage in Research on Access and Quality of Care for Their Rare Disease. And this was a direct outgrowth of my concern that I can't find anyone willing to care for my adult patients. It's very, very hard. Where we have multidisciplinary clinics in the pediatric hospitals, adult care is very balkanized. People do one thing, they try to do it well, but they don't have multidisciplinary clinics. And what are we going to do? And I would argue that this is not just a problem for OI. They say there are 10,000 rare diseases. It's a problem for 10,000 rare diseases. And so I love this cartoon. If we recognize that adults with childhood onset disorders are an exploding population because across the board, everybody's living longer, doing better, wonderful cartoon. Sometimes, even if I stand in the middle of the room, no one acknowledges me. This has been a very hard topic to get healthcare, particularly adult healthcare, you name it, to want to take on. Whoops. And so, whereas we want kids to move into adult care safely, the fact is many of our patients are falling off a cliff. We need to stop that. So what came out of it? Well, we have this long list, and I won't bore you with it, other than clearly as a foundation, we are working really hard to be sure that you have the tools, that everyone has the tools to move safely into adult care. And one of the initial byproducts of that has been the development of the adult health toolkit. And be sure you download it, be sure you have it, and be sure you share it with other folks. The other really important thing that's come out of it is that, once again, the realization that no one is going to do anything for us. We've got to do it on our own. And so I doubt folks have heard of Delphi panels, but they're really important. Sometimes there's just no way to do a big evidence-based survey or evidence-based study, or even if you're going to do it, it's going to take 20 years. But you need to have a starting point, something to tell doctors right now. And this process of Delphi panels is used for many, many, many other topics. But you start with a facilitator, you get a bunch of experts, and you start asking questions. You review all the literature. You take what's there, and you try to come up with expert opinions. They are only opinions, but they're based on a lot of data. And again, hats off to Tracy. She raised the money, and we have just about finished cardiovascular disease in adults with OI, and hope to be submitting that very first paper for publication really quickly. And it's a committee that's worked very, very hard together. And if all goes well, we are working hard to raise the money to do at least 7 or 8 more of these, so that when our patients go to see the doctor and they go, there's nothing out there, we can say, no, there are some really solid recommendations, and here they are. I just can't begin to tell you how important this is. Now, none of us are going to be immortal. I'm not sure I'd want to be, but we do wish lots of independence and a high quality of life to everyone with a rare disease. And so one of the other great innovations I hope you know that Tracy has worked on is helping folks with other rare diseases. And there's something called the Rare Bone Disease Alliance. And we host, therefore, something called an ECHO every month, which is an international program aimed at helping physicians and other folks, genetic counselors and whatnot, be far more able to identify individuals with rare disease and to initiate their care, make the diagnosis. Remember, in rare disease, we often talk about the terrible amount of time people wait to get the right diagnosis. How do we change that? We educate more people. And so I'm thrilled to tell you the OI Foundation has taken the lead in making that happen in rare bone disease. And then last but not least, again, with my concern about where do we find a safe landing place for our adults? How do we be sure our seniors get access to high quality care? We first had a program called Nowhere to Go, but Tracy is always more positive, and she changed it to Somewhere to Go. Hats off to Tracy once again. We held our first Somewhere to Go conference last October and came up with a long laundry list of things that we really care about. Important things being a landscape analysis. What are other people doing? And we're going to be holding yet another conference in the fall of this year, looking at what are the results of that landscape analysis, what are other people doing so we don't do something we don't need to do, and also to look particularly at what are things that advocacy organizations can do. Advocacy organizations have very small budgets. Where's the biggest bang for that budget? And then, okay, what are going to be our measures of success? So hopefully at the next conference, we can report on that. So what do the next 50 years look like? I don't know, but I would argue that it's going to be very, very exciting. The quality of care is going to change. Access of care, I hope, is going to change like mad, but we need everybody to be involved. And so, to everyone in the audience, please, if you have not signed up for the registry, be sure you do. Be sure you participate in the surveys that we send out. And please read what we send you, because we want to keep you up to date on all the exciting things that are happening. So again, this has been a very exciting and positive journey for me. Couldn't have done it without the incredible people in the foundation. It's been wonderful, and I thank you for all the things that you've done to help this go forward. Thank you very much. I now want to introduce our next speaker, who I think really needs no introduction. Reed Sutton is going to give the more scientific update. Poor Dr. Lee was unable to have a plane. They canceled his. Mine just made me wait a lot. So Reed, welcome.
Okay. Thank you, Laura. It's going to be very challenging to follow someone so passionate, dedicated, and inspirational as Dr. Tosi, but I'm going to give it a shot. Also, as Laura said, I'm a poor man's substitute for my boss, Dr. Brendan Lee, who was cloud struck by the airline issue yesterday and regrets that he's unable to attend, but I'll do my best to fill in for him today to talk about our brittle bone disease consortium that, of course, is a partnership with the OI Foundation. So the first thing I really want to emphasize is that Laura's analogy on the previous slide about investment being like in research, being like a 401k is true, I think. And so I want to try to convince you of that on this slide. And so what this reflects here is the number of medical publications on osteogenesis imperfecta, and it starts on the far left-hand side in 1970 and ends about 2 years ago. And one of the things I hope you can see is that there was this kind of steady increase up until about 2008 or so. And you see various timelines there, the identification of type 1 collagen genes as causing OI in 1985, Dr. Glorieux publishing bisphosphonate therapy in 1998, and then Roy Morello identifying recessive forms of OI in 2006. And then the Osteogenesis Imperfecta Foundation having the foresight to raise money and develop a program called the Linked Clinical Research Centers that were designed to advance care and research and improve outcomes for individuals with OI. And what you can see after that is that allowed us to apply for and receive funding from the National Institutes of Health for the Brittle Bone Disease Consortium that you'll hear more about. But the other thing that happened, kind of concomitant with the OI funding the Linked Clinical Research Center, you see all of a sudden there is a huge change in the trajectory of research publications with the OI Foundation's investment in the Linked Clinical Research Centers. And that's because, again, this issue like a 401k of leveraging funds and leveraging resources and really putting all the researchers together to improve outcomes and improve research and improve our understanding of OI. The National Institutes of Health, about 25 years ago or so, received funding in a congressional bill to establish research specifically for rare diseases. The way they decided to enact that research funding that the National Institutes of Health had received from Congress was to create a consortia called the Rare Diseases Clinical Research Network. Right now, there are about 20 different consortia, and you can see we are right here, the Brittle Bone Disease Consortia, and we're the only one that's dedicated to bone and connective tissue diseases. The other thing I want to emphasize that we've worked very hard at, as Laura has said, we realize from her work that OI is not just a bone disease, and we've really tried to address various things. And I think that's reflected by the different institutes that support the Brittle Bone Disease Consortium. And so you can see a list here. It includes certainly the National Institute of Arthritis and Musculoskeletal Diseases, because OI is in part a bone disease, but also money dedicated from Child Health and Human Development, from the National Center for Advancing Translational Research that focuses on rare diseases, from the National Institute of Dental and Craniofacial Research, and then finally from the National Institute of Mental Health. And you'll again kind of hear more about that, building on Laura's work. There are 12 sites across North America shown in yellow. Some of them are supported from the National Institutes of Health grant, and a number of them are supported by the OI Foundation's commitment to this program. These are the different sites shown here on the slide. And again, OI Foundation being right in the center of all of this. So what are the goals of the Brittle Bone Disease Consortium? So the first project we have is a natural history study. This is a required element from the NIH that all the consortia have to have a natural history study. We have enrolled over 1,000 individuals across the 12 sites in the natural history study, and they are continued to be followed annually or every other year for adults. We performed a early clinical trial of a medication called fresolimumab, which is an anti-TGF-beta antibody in individuals with severe OI. Again, you'll hear more about those results in a moment. We have an ongoing study looking at the efficacy of clear plastic aligners. So this is the Invisalign system in correcting malocclusion with OI, and I think you'll hear more from Dr. Retreve about that. We have performed a series of pilot studies looking at things like quality of life, various biomarkers, imaging, particularly craniofacial imaging, cardiovascular health, pain, and anxiety. We have a career enhancement core that's really led by the OI Foundation that's has as a goal improving in the engagement of patients, providers, and researchers, and particularly trainees, and in bringing new people into the field of OI research. You heard from Dr. Tosi about the contact registry. So I'm not going to read all these publications to you, so don't worry, but I kind of wanted to just kind of show you these on the subsequent slides are publications just from the Brittle Bone Disease Consortium in collaboration with others. And you can see that there are a lot on various aspects of bone, craniofacial, and dental health that have been published since we started right about 10 years ago. Quality of life and non-skeletal publications are shown on this slide and this slide as well. We also have a number of updates that the OI Foundation has posted on their website. And so if you want to hear more specifics about various aspects, like Dr. Retreve talking about the dental health, or Dr. Krakow talking about women's health, you can go to the OI Foundation website and these are posted there. Just since 2024, you can see that, again, we're continuing to push forward with better understanding of dental and craniofacial issues, with psychosocial and pain outcomes, as well as resilience and other factors in mental wellness. Again, a number on pain. There's a session, I think, tomorrow where you can hear more about pain. And I want to also call out Mercedes Celine, who is here, will be in that session tomorrow, and again is a junior investigator that was supported by the BBDC and kind of led this third publication here. So I want to go back and talk about the drug study that was performed. So this was what's called a phase 1 study. So phase 1 studies are required to assess the safety and assess various doses of a particular medication before moving on to, and these are generally done in a small number of patients and done before moving on to larger studies and more patients to see if a drug is really effective or not. But again, this safety one is very important because obviously we don't want to be treating people with medications that are unsafe, particularly large numbers of people like you would have in an efficacy trial. There are 2 doses that are shown. The graph that's kind of in the left-hand slide is showing the lower dose at 1 milligram per kilogram. And the one on the right is the higher dose at 4 milligrams of drug per kilogram body weight. And you can see that while there were kind of 2 individuals that did not get an increase in their bone density, that there were 3 that in the higher dose group that got an increase anywhere from about 2 to 10%. The decrease is just the waning effect of the medication because this was a single dose that was given. And so this is kind of what we would expect, that the bone density would go up, but because we're not continually redosing, again, the individuals lost that bone mass. So you may say, well, like, what good is this? This is like eight people, it's kind of a mixed bag. But one of the important things, again, was showing the promise of this. And so the company that had provided this medication to the brittle bone disease for free for us to conduct this phase 1 study, Sanofi, now has a phase 1 study of a longer acting anti-TGF beta antibody that they are doing. You can see the details of the study here. This is again, kind of an early phase 1 safety study where they're getting a single dose and they're going to be looking at mainly at safety, but also things like how is the drug distributed throughout the body and metabolized, and also some preliminary things looking at efficacy with bone mineral density. And so again, kind of important in the OI, the Brittle Bone Disease Consortium and the OI Foundation kind of leveraging this in order to set the stage for biopharma companies to come in with and develop new therapies. This is just showing, again, there are like presently 3 clinical trials that are enrolling or ongoing right now for different products. And I also want to emphasize that the Brittle Bone Disease Consortium has now provided information from our longitudinal or natural history study to 3 different drug companies who are working on new therapies. And you might say, well, why are the drug companies interested in a longitudinal study? Well, the reason is when they go to the FDA, they need to know what outcome they're going to use. And if they don't know how many fractures in a year a 12-year-old with OI has, it's very hard for them to design their study. Moreover, these are very expensive drug studies, and they need to know how many patients that they need in a study to show a particular effect. And so with over 1,000 individuals in our natural history study, we can provide biopharma companies with data that they can use to wisely plan their clinical trials to best ensure success when they go to the FDA for approval. And again, if you want to kind of learn about clinical trials or look for clinical trials, this website, clinicaltrials.gov, is a federal website. All drug studies and biopharma companies that are planning to do a study and apply for approval from the US Food and Drug Administration, FDA, are required to post the study at this website. So again, this is a great resource if people are looking to participate in research, how they can find clinical trials. So there are a variety of studies in progress. I mentioned the longitudinal study. the study of clear plastic aligners that is ongoing. Building on Dr. Tosi's work, one of my colleagues, the psychologist, Dr. Eric Storch, and his team are looking at understanding psychosocial needs of individuals, and particularly, again, as Dr. Tosi had mentioned, what we have come to realize is that these issues of pain anxiety, pain interference, and pain catastrophizing are really important issues for individuals with OI, and we're working to develop treatments to address all of those issues, as well as to learn more. Dr. Raggio, who unfortunately is not able to attend, is leading scoliosis and cardiopulmonary outcome studies for the Brittle Bone Disease Consortium, and Dr. Krakow, that you heard from, I guess, the day before yesterday in the Women's Health Forum, is looking at pregnancy and women's health during pregnancy and lactation. And again, this is the website. If people want to go and learn more about participating or learn more about the studies that we're doing. So again, so far for the clear plastic aligner trial to correct the malocclusion or and that is common in severe forms of OI. So far, there are 13 individuals enrolled in the treatment arm, and there are 3 individuals who have completed 1 year on treatment. The study, of course, is ongoing, and we will continue to enroll. This again, Dr. Retrovi worked really hard with the companies manufactures this and got them to provide all of these things for free to us, because again, as you know, anybody who's had clear plastic aligners knows these things are not cheap. And so it's really great that they provided, you know, he got them to provide that for the study for free so that we could conduct the study and again, provide this for free through a research project to individuals with OI. The OI Foundation conducted the impact survey. Again, I think there's more about this shown here along on the OIF website. That was, again, I think it's probably also on the OI website, Tracy, right? You can see this, but this has helped us to really prioritize what we are doing in the Brittle Bone Disease Consortium. And again, I'm not going to kind of read all of these, but again, kind of in the upcoming grant renewal that's due here in just a few weeks, we are really kind of looking at this and trying to focus on, again, some of the things like pain and fatigue that you're seeing here as top issues identified in the survey. So I want to say a bit about the well-being study that's ongoing. So this is the one that's funded by the National Institutes of Mental Health. There are 3 aims. The first 2 are completed. So the first one was kind of small focus groups and discussions to better understand the issues that individuals are experiencing regarding mental wellness and health. We have now incorporated a series of questionnaires, again, focusing on wellness, particularly again on things like pain anxiety, pain interference, pain catastrophizing, into our longitudinal study that everybody is completing annually so that we can get not only more data, but data over time to see how that changes over time and to see how that changes with various life experiences, whether that's transition from childhood to adulthood, whether that's a surgery, whether that's some other treatment that happens, so that we can really understand those sorts of outcomes. And then finally, a study that's ongoing is in-depth interviews with 300 individuals with OI, again, to get more information about these issues. And I don't know if Gianna is in the audience, but if she is, stand up and wave. She will be at a table out here to the left, to your right-hand side of the ballroom. And we'd love to have you sign up because, again, I think, as Dr. Tosi said, you know, hopefully we both will convince you why it's really important to participate in, engage with, and invest in research to improve outcomes for individuals with OI. This again is just kind of showing the first 2 phases completed, the 3rd phase again ongoing. Please sign up. We're 160 some odd on our way to a goal of 300. As I mentioned, Dr. Krakow is also performing a retrospective study collecting medical records to understand health issues of women with OI who are pregnant. There is a concern based on her preliminary data of increased rates of cesarean section and surprisingly increased rates of maternal bleeding, often requiring blood transfusions. And so again, if you're a woman in the audience who has had a child and it would be great to have your participation. This is the email address for Dr. Krakow and this study if you would like to participate. And then you heard again from Dr. Tosi about kind of the OIF-led community engagement. And again, kind of focusing broadly on everybody here in the audience and other people with OI, healthcare providers, researchers, and again, importantly, trainees to bring new researchers or clinicians into the field of OI research and OI care through, again, a wide variety of items. I think that you've heard about, hopefully, over the course of the meeting so far. There are also a series of studies from OI researchers and biopharma companies looking at various other treatments and new therapies, looking at kind of non-bone issues, particularly, again, things like cardiopulmonary issues and issues related to the eyes and craniofacial and dental health. So as I mentioned, we are in the process of submitting our renewal here in the next few weeks. The National Institutes of Health program that funds this decided a few years ago that we could have a maximum of 3 cycles. This would be our 3rd cycle, and so would be our last cycle. And so we're really focused on what data is it that we can collect in this last cycle as a big push to serve as a living resource for research well into the future. And so we are really focused on this issue of legacy and ensuring the success of research going forward. And so we so far have collected over 4,000 spinal x-rays on individuals in the longitudinal study. These will be analyzed by Dr. Leanne Ward at the Children's Hospital of Eastern Ontario in Ottawa, read centrally by her group. And again, we will target 7 years of follow-up data for individuals. And again, these will be read and stored for future research on OI. We will expand the pregnancy study to focus broadly on women's health. And again, that'll be led by Dr. Krakow. Continuing on dental and oral health, but with a new focus on temporomandibular joint or TMJ disease. And then finally, performing whole genome sequencing on all participants in the longitudinal study that again will be uploaded to a secure National Institutes of Health public website that again will be a resource going forward for researchers well into the future. We will have cognitive and behavioral intervention for chronic pain. Dr. Marie Eve Robinson, also in Ottawa, performed a pilot study that has been submitted for publication, looking at mindful self-compassion to address some of these issues of pain anxiety and pain interference. Showed that it's feasible. And again, although it was a small study, she was able to show reduction in pain anxiety during this brief few months of training of mindful self-compassion. And we will be proposing again in the renewal to do a much larger study of hundreds of individuals with OI using mindful self-compassion as a tool to try to help reduce pain anxiety and pain interference. We're, as I mentioned, going to be focused on a lot of imaging resources for the future, not just spinal imaging, but all of the imaging from studies led by Dr. Retravi for things like the dental panorex imaging. We have 3D CAT scans and other imaging that again will be used. And then again, we will continue with the career enhancement pilot studies and advocacy that that I've mentioned about. So this is our group at our principal investigators meeting last year. And so it takes a small village to do all this work. And so I want to, I'm standing up here representing many individuals and the OI Foundation in all of this hard work, as well as our external advisors. So I finally want to say thank you, because it is the dedication of the OI community, the participation and investment in research that has really allowed us to move forward with all of these sorts of research studies. And again, if you've not participated or engaged with research, I hope Dr. Tosi and I have convinced you about the importance, again, of participating and investing in research to advance care. So I want to thank everyone for their time. And Tracy says we have time for questions. So thanks.
Hi, I got the first mic. So I am wondering about digestive issues. Digestion, we have a huge problem and everybody keeps ignoring it. Cool.
So the question, I think, was about digestion issues. And so, yes, we don't have a project focused specifically on that. We do collect information in the longitudinal study about that. And again, could be analyzed or again, could be leveraged for future research studies. So even though the BBDC consortium can't get funded for more than one more cycle, again, one of the things that can happen is applying for different sorts of National Institutes of Health or other grants to address some of these other issues. Thank you.
And I would add to that, as you may know, at some of the previous national conferences, you know, yeah, we need
Maybe
to get apart
too
because we have
close.
competing microphones here. But we've had some round tables on this, and we really do recognize how important it is. One of the big challenges is how few GI people have any interest in this at all. It is one of our high priority items for a Delphi panel because we're hoping it will do two things. One, get those folks who have a little bit of interest come up to the table, and two, to get a publication out there. But boy, do we have a lot to learn on GI. Couldn't agree with you more.
I have two questions. The first one's really easy. Will these slides be made available for us to look at? And the second one is, I can't agree with you more about the multidisciplinary approach and the lack of care for adults in rare diseases. OI is just one of the many. Even the president of the National Pediatric Hospital Association said that it's a problem because, you know, patients are wanting to stay in the pediatric hospitals because there isn't, you know, this managed care. I know my PCP even, you know, they'll recommend the specialist, but once you go to the specialist, they kind of wipe their hands clean of it, and you have to manage all those specialists and everything. So my question to you is, why is that so difficult? I mean, I understand maybe the PCPs don't want to do it, but why isn't any of it seems like an entrepreneurial area, you know, for somebody to take on either just a separate management care company or the adult hospitals. Why is there not like a complex care center in that realm? Do you know?
I can speak to that a little bit. First of all, you have to recognize that adult care is organized in a very different fashion. And so whereas multidisciplinary care clinics have been a part of pediatrics since forever. They do not exist in the adult realm. So you're dealing with a bunch of balkanized countries who don't want to talk to each other because there is no tradition. Ironically, the thing that I think is going to push this forward is a group called Gut Transition, who you may or may not have heard of, but if you haven't, you want to go to their website. And, you know, life is life. And one of the leaders is somebody I went to medical school with and whatnot. And she's been, the poor lady has been coming to my Christmas party for 40 years. And for 40 years, I said to her, look, all your interest is in transition is great, but you got a problem if there's nowhere to go. Oh no, I didn't understand anything. I was the dumb orthopod. So luckily, it took her a long time to hear, but it's interesting to me, it wasn't rare disease that pushed her over. What pushed her over is the survival of the individuals with complex disorders that aren't rare diseases. Whether you're talking cerebral palsy, heart disease, etc. And so the irony is they have a very, very interesting white paper that's really going to help us move forward, in which they talk about how we have to reimagine adult care. And there are a lot of parts to it. So medical school doesn't focus on that. It's dealing with these multiple disorders. We've got to start changing how the doctors are trained and how the doctors think. They recognize, and they have more money than we do as individual rare disease organizations, to try to move for legislation that is better for care coordination, because right now there's almost nothing out there to finance care coordination. And their whole piece goes on. They've got 10 major recommendations. And if you go to Gut Transition and white paper and complex care, you'll get to it. It's a really good piece. And so with our Somewhere to Go project, we're, you know, the one question is, how do we partner with them and yet move it even further to deal with the issues of rare disease? But this is not going to happen overnight. And this is, again, where we need everybody to be involved, speaking to congressmen, any opportunity you have to say, this is important. And it's estimated that there are at least 30 million people in the United States with rare disease. So the definition of a rare disease is less than 200,000 people have it. But you start saying 10,000 diseases, you got a lot of people. And so the other question becomes, how do we partner with other rare diseases to be sure that congressmen hear it? But it's going to be a long change. And so again, coming back to my talk, we as a foundation are working on the what can we do now? Thus the Delphi panels, which we're working to finance. All the work that's going on in the BBDC. There's no one easy answer here. There are a lot of pieces to this puzzle. We need everybody involved with every piece they can be. Long-winded answer, I apologize.
And if I could add to even that to make it more lengthy. So I think that, you know, one of the things to consider, again, OI is certainly investing right now in transitions of care, but kind of that the reality is these clinics overall are money losers for hospitals, right? Where they make their money is, you know, if there's a surgeon in the multidisciplinary clinic and they can go do a surgery in the OR on somebody in the complex care clinic, the hospital will make money on that. But the complex care clinics or the multidisciplinary clinics are money losers for hospitals. And that's just an unfortunate way of the way our healthcare payment system is structured. And then to your other question, I think we're fine probably with sharing the slides, but we'll talk with the OI Foundation about how best to do that.
Hi, I'm a pastor and a board certified child and adolescent psychiatrist who's a faculty member at New York Medical College. I have 2 rare diseases. I'm on the board of Physicians for a National Health Program. I take insurance. None of my colleagues in New York do. I don't earn a lot of money. I pay $3,000 a month for my health insurance with a deductible. And I have had 3 surgeries in the last 4 years. And I rely on an inheritance from my father to survive because I've worked with the poor my whole career, but I had to leave the clinics because of the way healthcare is structured for profit in this country. Poverty is the 4th leading cause of death, and it's very expensive even to come to these conferences. And I actually did participate in a research study for OI and wound up getting billed and had to fight for a year to not get debt collectors after me for doing research. So I plea for physicians to join Physicians for a National Health Program, because whether you have a rare disease or no disease, most of my patients are physicians who are depressed. We have a volunteer program for psychiatrists to treat physicians who are at risk of suicide, who are afraid of getting mental health care because it'll jeopardize their licenses. So I think unless we have health as a human right in this country, that we're all going to suffer. Thank you.
Thank you.
Thank you very much. Oops. Yeah.
Yes, I have a question. Excuse me. What are y'all, is there any research with people at OI that have been treated for cancer? And some of the medications they take suppresses the hormones, and the treatments and stuff really wreaks havoc on their bodies and their bone density and stuff. So is there any research looking into how cancer treatments affect people with OI? And I say this because I'm going through this journey right now with my spouse.
Goodness, I think we're very sorry to hear that. I think that, you know, there are challenges. I don't know of specific studies that are looking at that. We do, in the Brittle Bone Disease Consortium, collect information about medications when people are coming for their annual study visit, as well as other health-related issues that they would experience. And so we do collect that data. I don't know how many individuals that we have that have experienced cancer or needed treatment for cancer during that, but I don't know of specific studies focusing on that, unfortunately.
I don't either, but I would argue that that's the sort of thing where I'll be happy to talk to Tracy, where being a member of the registry is really important, because we can get a small answer to, gee, how important is this? And certainly all the data is that cancer is increasing in the United States, particularly among young people. So we have a vested interest in learning this. And I thank you for the idea. And that's why meetings like this are so important. You got to give us these ideas. We don't always see things that you see. Thank you.
Hi there, my name is Emily Vorty, and my background is in part in policy. And Dr. Tosi, I'm so curious about your call to lobby Congress and our Congress people. Can you expand on that a little more? Is the argument to Congress implementing kind of a stick as opposed to a carrot approach, or vice versa? Or what's the policy lever there?
Is it my back on? Yeah. So ironically, I have not pushed Tracy in the policy realm for the simple reason that it's so bloody expensive. And there are other organizations that are doing it. But I do feel very strongly that we have to partner with them. And this is where partnering, for instance, with Gut Transition to ensure that there's more money for care coordination. Could there be a carve out for rare disease? Right now, we are already moving forward to support a group that wants to get telemedicine back. So during COVID, I had licenses to burn because they were given to me left, right, and center, that people wanted physicians to be able to communicate across state lines. However, licenses are a big money maker for states. As soon as the COVID pandemic ended, so did all those licenses. So I'm very limited in where I can do telemedicine. Should there be a carve out for rare disease? Because I think most people believe centers of excellence are a great idea. Well, that's a great idea as long as you can get there. It's not a great idea if you can't. And so how do we ensure that the same quality of care is available to everybody, no matter where they live? And I would argue telemedicine is a big part of that. So we are partnering. We are not looking at that directly simply because it's too expensive. And as we look to our responsibility for the other rare disease organizations, we're looking harder at the questions of what can small groups do to help their entire community. So both important. There's what we can afford and what we can't. More questions? We're open. And boy, do we welcome your ideas. This is how we get better at what we do.
Sorry, I think this is a question for you. What's happening with the OI clinics around the country? Because I think mine at Kennedy Krieger has morphed. They're awesome, but I think there's no longer a doctor specializing in it anymore. So I'm just curious if that's happening all around the country and if we're even naming them anymore.
So at our website, we do have, and you may want Tracy to move to this, but we do try very hard to communicate with all the different clinics. Kennedy Krieger has hired a new team. They're young, but they're really nice and have introduced themselves to me, and I'm very excited to be supportive of them. One of the things that we did that we just alluded to very, very quickly in our talk today is that we became concerned because we had 50+ clinics listed on our website, but in fact, on a regular basis, we only communicate with about 10 or 15 of them. And we have wonderful traditions of participation in the scientific meeting and whatnot, but we had no idea what was going on in these other places, and that's inappropriate. So we now have twice a year a town hall meeting where we try to get at least one person from each of those clinics to come on to a call to talk about what are some of the innovations that are out there, how it's impacting our patients, et cetera. Because I do believe that's another responsibility of the foundation. You can't just sit there in your ivory tower. You've got to be sure that you're lifting all of the boats throughout the community. So we are trying to do that. We can't change the politics of what happens locally, but we can try to educate the folks who are there as best we can. Love to answer another question. Yes, ma'am. Wait 1 second for a microphone, if you would.
Would it just be easier to take the children's facility and extend the age out?
That's a difficult political issue all the way around. At my own institution, which is always my best example, I have a lot of clinicians who say, I was never trained in adult. No, we'll hurt them. Even though, in fact, so many of my older patients are pediatric sized. I think that there are several arguments. So if you look around the country, usually 18 or 21, 22 are the cutoffs. I think the really innovative organizations are going now to at least 26 to mirror Obamacare and frankly, to mirror the developing individual. That early adulthood there are so many other challenges. Can we just get medicine off the table till you're really out there with that first job and you're established? So I'm hoping you're going to see a move to 26 across the country. But you'll see that departments of health get really nutsy about this issue and don't want adults in pediatric hospitals. So there isn't an easy fix here, and it's all politics are local, and I would argue that for this issue in particular, you're going to see great variability around the country.
Yeah, I agree with Laura, and I think one of the challenges too is I think hospitals are concerned about liability, right? Particularly if you're, I agree with Laura, and I think most people in the room probably feel like, well, like is 26 really that different than 21? Probably not, right? But when you start getting 50-year-olds that have very different medical issues than 26-year-olds, I think the hospitals get very afraid of like, oh, well, we don't manage, pediatric hospitals don't manage heart attacks, right? That just like generally does not happen, certainly does not happen commonly in the pediatric age group, right? But it's something that's very common, quite common in adults. So I think there are a number of issues, and I think that, I agree that a rational person might say, well, why not just equip pediatric hospitals to continue to take care of these complex patients with rare diseases? But I think the reality is that's probably not going to happen, right? For a variety of reasons.
So I married an economist. They're kind of evil. They don't see good and bad. They sort of see the issue of the marketplace and what is the marketplace value of this thing. And this is where I get back to the public policy issue. How do we change the incentives that will get the folks in the adult care institutions to want to care for our patients? And that's going to take a lot of creative thinking. But we got a lot of creative people in the room. Give us ideas that we can carry forward, because we've got to change the system. The question is, how do we do it? Tracy, you're standing up. Sorry. Yes, ma'am. Wait for the mic, if you would. Coming right behind you.
Thank you. Thank you very much. So my background is also in healthcare, but more on the management side of it. And one of the thoughts would be is there is a ton of data that suggests that care management and multidisciplinary teams are actually cost effective. So one way to go, rather than just Congress, I would recommend that you partner with one of the large insurance companies, because until you figure out how to get it paid for, ain't going to happen.
Excellent, excellent. Yes, ma'am. All righty. Okay, one more question.
Dr. Tosi, I have expressed this to you a couple of times. We are fortunate to have you in the Washington area. But as a father of a son with the OI, I've always been wondering, what is going to be the life of OI when you retire? Because there has not been no mechanism put in place for us parents to see where to go. So my question is, what is the plan of the OI Foundation and all those in charge to make provision for us parents, for kids, after you are retired?
Well, so I plan to be there for a bit longer, but this is not a joke. I am considered not a real asset because I don't make as much money. I do rare disease care. I don't do spine, which in fact prints money for the institution. These are very serious issues, I think, for everyone in OI care. It's why it's so important that Tracy and her team are trying to bring along new clinicians, new researchers and whatnot. And you'll be interested to note that on Thursday, I have a meeting with the hospital foundation to look at what we could do to incentivize my younger colleagues
to be interested, because it's not a joke. If you can't raise the monies to supplement what the individual is doing, I cannot attract a young person. You are absolutely right, but I'm on it. I'm trying hard.
And again, as Dr. Tosi says, the OI Foundation has really invested a lot in the various programs you heard about, the Tele-Echo series. And so we didn't have a time to talk much about that, but that basically, invites people from all over the world, including trainees. And I send it to all our trainees to be sure they sign up and participate, because there's a presentation, and then Dr. Tosi has it structured beautifully where there's then a dialogue at the end where people can ask questions about their patients to the expert. The travel awards for various things, the awards for young investigators, the Bookbinder family and the OI Foundation Science Conference is always very deliberate about ensuring that young people are invited to the annual OI Science meeting. And so the OI, certainly there's a lot more that could be done, but the OI Foundation has really worked very hard and is investing a lot of money in trying to ensure that the next generation of physicians and clinicians and researchers is there and committed.